Welcome to Collaborative Intensive Bridging Services, otherwise known as CIBS. CIBS was a service developed particularly to help at-risk youth and their families. Now, these children were typically the type of kids who would go to long-term residential treatment centers. And back in 2009, Dakota County was experiencing just that situation. Many of their children were going into residential treatment centers and were staying there longer than expected, or they were going in for multiple episodes of treatment. And Dakota County asked the question, how can we do this differently? The result was the formulation of the CIBS model. Now, CIBS is pairing intensive in-home therapy along with a short-term residential program and merging these two together to provide a brief integrated services for youth and families, really trying to minimize or stop problem behaviors that these youth are exhibiting. There's actually 3 phases to the CIBS program. In the first phase, an intensive in-home therapist goes to the family's home and begins a 2 to 3 week assessment process with the family. In this situation, the therapist is gathering information from both the family, the child, other systems who might be involved with the family, including people like referral sources. It could perhaps be school personnel. Really, wherever the child and family are interacting, we want to know information about that will help us better understand the situation with them. During that 2 to 3 week time frame then, the therapist is formulating their hypothesis or their best guess as to what are some of the things that are affecting some of the current family functioning. One of the most significant shifts you'll see in this type of work is that although we are working intensely with the child, it is really the family system that is the focus of treatment. So by the end of that first phase of treatment, we want to have the RTC answer some pretty specific questions about what's going on currently for the child. The therapist that started in phase 1 will continue during this 30-day time frame at the RTC. What also occurs during this time frame is that the in-home therapist staff works closely with the RTC staff. Oftentimes, RTC staff may be providing co-therapy during this time frame. We'll be providing frequent contact with the family regarding their child's progress there. There's usually 3 staffings that occur during that time frame at the RTC, so the family is well informed about the progress being made there. One of the things to note about this experience is that children within a 30-day time frame typically are not fixed. They are, though, exposed to certain skills and are expected to practice those both during the regular day at the RTC as well as during home visits. And home visits occur on a frequent basis during that 30-day time frame because we want the kids and families practicing the skills necessary to help them be more successful back in the home setting. After the 30-day placement, the child goes back into their home. And then there is, in phase 3 then, it's intensive in-home therapy follow-up, which occurs typically 6 to 7 months following that second phase of treatment. During this time, the same in-home therapist that started with the family continues the work with the family to continue to solidify the gains that were made during the earlier phases, as well as the ongoing work that is necessary to cement the changes that have occurred in a more permanent way with the family. There are 4 partners that are part of this process within CIBS. The first one, most obviously, is the child and the family. The second partner is the Children's Mental Health Case Manager. Third partner is the intensive in-home therapist, and while the fourth is the residential treatment center or RTC that is involved with the family. What's different from this service compared to services as usual is that all 4 of those entities are expected to be collaborating and working closely with one another to help benefit the child and the family overall. As part of that, there's a high level of communication and collaboration that occurs between each of those 4 systems. One can expect that there's going to be at least weekly contact between, for instance, the therapist and the case manager, often more frequent contact between the therapist and the RTC staff while in placement, the child is in placement, and typically the therapist is having frequent, multiple contacts a week with the family in some sort of capacity. That could be individual, it could be family, it could be couples work, whatever is being worked on that is felt to offer the most benefit to the family in changing problematic behaviors. Welcome to our ongoing discussion regarding collaborative intensive bridging services. And we're going to talk in this segment particularly about the role of the therapist in this work. And we have with us a couple of CIBS therapists. We have Tyler Doherty and Stare Sampshire. Thank you for joining us. And so we're going to continue this discussion about really this model and particularly the role of the therapist within this model. Talk a little bit about how the role of the therapist is different doing this type of work than really in-home therapy services as usual. Maybe Tyler, if you could start.
Sure. The main thing for me that I think about that's very different than traditional roles I've played as a therapist is the fact that we follow the family through the entire process. So from the assessment process, and then while their child is at an RTC, we're still working with the family and with the child and staying very involved through that process. Whereas, in other types of programs or work I've done in the past, I wouldn't necessarily have a lot of involvement during a time while a child was at an RTC or something like that. And then you're there as child comes home from RTC as well. So the family and the child understand that you're right there at the backbone of the thing throughout all of it, and I think that continuity has proven to be very helpful for the families and parents and children.
Right. Sarah, I mean, this is a highly collaborative model, as you well know. Maybe talk a little bit about the nature of the collaboration. Again, maybe how it's different than services as usual and what people can expect as part of that.
Mm-hmm. I think going off of what Tyler was saying, you're there in the beginning, you're there in the middle, and you're there at the end. But throughout that, you're in constant contact with the social worker, often the social worker's supervisor, possibly. The supervision is from the county level is connected to the supervision here at FACS, and then also at the RTC. So you're collaborating with numerous people at any given time. And I know in some of my experiences with some of the RTCs, we're also collaborating with the unit team leads, the unit staff. It's not abnormal to get a phone call from a staff person on the unit saying, this is what's going on with your client. I can't get a hold of the RTC therapist. What direction do you want me to take with this? So there's that collaborative piece in all of the identities and entities that are playing a role in the CIBS cases.
Okay. And of course, this is different for the family too, right? This, even more so than perhaps some intensive in-home therapy services, this is even a notch above that. Maybe can you speak a little to that?
Well, just the fact that these families are trusting to send their child off to an RTC where the child's going to receive, very intensive services for their individual needs and learning additional skill sets, but the difference is families, I think, feel much more connected to that process rather than a more traditional model of a child going to a treatment facility. They're very involved. They're there all the time. We're continuing to do just as many family sessions and meetings as we would if it was all just in home. And having myself and all of the other players that Sarah talks about being involved on a daily, certainly weekly basis, there's you decrease that there's almost no disconnect while the child's out of their home for a short period of time.
Right. Mm-hmm. I think we talk in this model a lot about momentum and that we want to be moving things forward in this process, and that happens a lot, particularly in the early part of the case. Maybe Sarah, can you talk a little bit about kind of what people can expect? What do families, what do referral sources expect in those? Maybe let's start with the first phase. What do you typically do?
Well, I think because that first phase and the second RTC phase go so fast, it's just like you blink and it's over. I think that families can expect for a CIBS therapist to come in and want to hit it hard. We're gonna fill out the intake paperwork today, we're gonna do a genogram today, we're gonna talk about the rules, rewards, and consequences in your home, I wanna know the structure. And it's really fast-paced, it's really rapid. And I think parents also need to be aware and be expecting that it's as much work, maybe even more for them as it is for the child going into the RTC. I think a lot of times with traditional models of therapy, it's here's the identified patient, let's just focus on that. And it's really not that way. What we know about kids is parenting influences their behaviors. So if we're trying to improve behaviors, it's more really about the structure and the parenting. So I think parents need to expect that they have a lot of work to do.
Right, right, yeah. And talk a little bit more in that first phase. I know it's an assessment phase typically for the therapist. Talk about what they do during that phase, and again, what can parents expect?
Well, usually what I do is I'll do 2 to 3 kind of diagnostic interviews with the family, but I also like to take some time to sit back and just have, some conversation with family, but kind of observe the dynamics and understand how the roles are interacting with each other, and how maybe their environment is impacting them. So I'll do that. I think also too, parents should expect that we might ask for some collateral interviews with doing a diagnostic assessment, because that first piece is so important to get as much background information in a really short amount of time so that we're really prepared for when this child and the family starts the RTC portion.
Right, right. So I think that's, again, one of the differences with this model, right? That we're taking what we learn in those first 2 to 3 weeks of our involvement and really setting up the phase 2, which is the 30-day, usually RTC portion of the program. And so maybe, Tyler, talk a little bit more the setup with that, particularly, the questions that we're going in with wanting to know based on our assessment.
Yeah, in that first phase, heading into the second phase, we're really, to come right off of what Sarah's saying, we're really, I think it was just mining the system, the entire system. Anyone else that knows this family, has worked with this family, other county workers, referral sources, et cetera, and the family system themselves. So you can narrow in as quickly and I should say efficiently as possible and accurately an assessment on what are the real core issues in this family system, not just the child's behaviors or what mom and dad might or might not be doing that's successful in parenting, and really narrowing that down as quickly as possible. And I think parents will find that we're always aiming at that, to get right down to the nitty gritty, and which is often what stuff is that maybe people are not talking about. Right. Right. And then take that understanding to the RTC and create a very focused set of a couple of skills goals for the child as they're at the RTC. Communicate that pretty clearly to the RTC that this is what we'd like this child to be working on, and it's tied directly with, symbiotically with the goals, therapy and skills goals that we're working on with mom and dad back at home and together as a family. So all of that is integrated, right, and all aiming toward the same goal, right, which we would be identifying again in that assessment for what exactly is that's the first question, is what are you looking to, where do you want your family to get to? What are we looking to change here?
Right. And in phase 2, there's a lot of contact, right? Yeah. Still, even though the child may be in RTC, a lot of contact with you. Yeah. Maybe just what are the general expectations around that?
So it can be as much as daily contact, definitely 3 to 4 times a week contact, and that's including meeting with mom and dad and the rest of the family members at home, meeting with the child at the RTC individually, or perhaps with the RTC therapist, having mom and dad and family up to the RTC to do family sessions. Child's going to be coming home weekly for regular home visits, so and that's another opportunity to do family sessions and keep working toward that common goal. So there's a lot of involvement during that 30 days, which is part of why, as Sarah says, they go by really fast because you're doing a lot of stuff. And then the rest of the contact would be keeping in close contact with referring workers and so forth to let them know what's going on and keep them in the loop. You're going to we're staffing with those other professionals at least, I'd say 3 times at least during the 30 days to continue to make sure that everyone on the team is still on the same page. We're all on the same clinical track, working toward the same goal for the family. Very intensive amount of interaction among everybody. Very collaborative effort that way.
One of the challenges of kids going into long-term residential centers, or RTCs, is that even if a child is successful within the RTC setting, helping to transfer the skills that they've learned at the RTC back in the home is always a challenge. The term for that is generalization. So we want the kid to generalize the skills they've learned back into the home setting, or perhaps other settings such as school that the child may struggle in. That is best done by having the family actively involved in the treatment process, and at times, often due to distance or some of the other factors that can affect RTC involvement, the generalization becomes much more difficult. And one of the things we also know is that a child does best when they stay involved and engaged in their natural support system. One of the challenges, again, of RTC, when you take a child out of their home and place them in an RTC, it pulls them out of their natural support system, which could be immediate family, extended family, friends, neighbors, church folk, whoever, and put them in a somewhat artificial environment with other negative peers, which can create problems as well. So we want to, as much as possible, minimize risk factors and keep a child in the home as much as possible to continue working on the issues and working in the environment where the child is having difficulties. Sarah, I wonder if you could speak a little to, in some ways, the philosophical shift that people have to go through in this model. For instance, particularly in the phase 2 portion, oftentimes kids aren't going to come out of that phase 2 portion having great skill sets and being able to transition right back in the home. In some ways, it's exposure to skills and perhaps some practicing of skills. But maybe talk about some of the shift that both parents, RTC, referral sources have to go through in their understanding of that.
I was thinking about that actually when Tyler was speaking, because I think so many people assume that RTC is like the magic bullet, and that RTC is just going to fix everything and it's going to be magic. But kind of what I was saying before when we first started this was that parents play such an integral role. So I think the shift comes in is, one, you can't expect perfection. It's just not going to happen. We're dealing with human spirit here. It's just not going to happen. And I think it depends a lot upon what happened at home, what kind of quality work happened when the child was away. Did the siblings have any behavior shifts and changes? Did the parents learn any different skills? How are they going to react when the child comes home? And then I think that there has to be a shift. So many times I see families that are so exhausted when we first start that RTC is like, oh, thank God, I need this break. But it's not really a break. So you have to shift the way you're thinking about things, because, like I said, it's going to go so fast. This child is going to come home, and you have to put these skills into motion, and it's not going to be a typical 6-9 year long RTC stay. It's 30 days, and it's hitting it hard the whole time.
And I think that speaks as well to the reason why we do such a lot of work with the parents up front. Again, going back to phase 1, making sure that they are very clear on exactly what this is going to look like, what it's going to feel like for them, and setting the expectations up on the front end between everybody. So parents don't have unrealistic expectations or simply misunderstood expectations. Yeah.
And I think too that part of the shift as well is that, like I said, so many people think RTC is the magic bullet. But for myself and for us, I think what we think is the magic bullet, if you want to use that terminology, is working with the family system. So it's really not, in my opinion, not RTC that is making the big difference. It's the family work, the maybe the break that's needed. But to me, the magic bullet is getting this family together in different environments, working on those skills as a system, not as an individual. So that for me is the paradigm shift.
Right. And so families transition out and child transitions out of phase 2 and goes to phase 3, which is basically back in the home and follow-up care from that. Maybe Sarah, talk a little more about what's part of that phase and the work that's done in that piece.
I think that there sometimes is a honeymoon piece of that phase. A kid will come home initially, and for each child it's different. So it might be a couple of days, it might be a week, it might be a couple of months, where things are really different. Things feel good, things feel positive. And if that work isn't continually worked on, skills are practiced. If parents aren't enforcing good things, good behaviors, catching the kid doing things right and good, they won't stick. So that piece to me is, in my opinion, the most important part. Now that we have these skills, what are we going to do with them? And I think that sometimes when the family is in the honeymoon phase, it feels so good that, okay, Sarah, give us some space, give us some time. But in my experience, that's the time to hit it the hardest.
Maybe Tyler, just talk about the kind of termination process. So what do therapists go through as part of looking at trying to close out services under this model?
Well, the first part of that is, again, going back to the front end of helping parents understand sort of what the typical time duration of the program is, so they've got a little bit of an expectation, and also, again, as far as the overarching goals that we set up, making sure those are appropriate goals and attainable goals in that time period. And then as we're starting to approach, it's not only the length of time of the program, but watching to see, are we starting to or actually are meeting those overarching goals, and being in sort of a constant open communication with the parents and the child about that. I think of it as almost like you're always working toward closing. Right. How are we doing on meeting these goals? How far are we coming with that? How is the family feeling about it? And then as we get into later in phase 3, we get into an area where it seems like the overarching goals are being met fairly well, or maybe 100%, or as close to that as possible. As Sarah says, no one's perfect, but then it's about talking with the family about how to start to transition myself back out of their family system, that I've become a bit of a surrogate system member at that point. And talking about what sort of ongoing services they might need as we close, looking at how long of a period of time of them, the family and the child, everybody maintaining the success that they're having. What feels like enough time to say, hey, we think we got this, kind of like. But again, if there's any ongoing services that would be helpful to help continue the child's practice and getting more and more successful with their skill use, or mom and dad, there might be some other family system issues that could be worked on that weren't necessarily a main focus of our program, that mom and dad or any other family member group could continue to work on, but maybe with a different type of a service going forward. So talking about all that, but again, just having it be a very open, collaborative conversation with the family all the time about that.
Okay. I'd like to shift gears a little in this conversation and maybe talk a little bit about kind of what we've learned, or maybe some things you've learned as a therapist doing this work, because it is different oftentimes than therapy as usual. And so Sarah, if you could talk a little bit about some of what you've learned in doing this, what would you like to highlight perhaps to other therapists who would be looking at doing this type of work?
I think for me personally, you're in contact with these families, I mean, for me, probably every day, depending upon the intensity of each case. And kind of, as you said, you become a pseudo member of this system. Mm-hmm. That happens to me frequently. And I think that keeping boundaries is really important, because you do get pulled into the family system when you're with a family nearly every day, whether that's via phone, in the car, at the RTC, at the house, meeting the neighbors, meeting grandparents, aunts, uncles, all the informal system supports. Which kind of leads me to my next point. I was thinking about the piece of transitioning out. And I always try to help families find informal supports so that there isn't sort of this void when the therapist leaves the system. And I think when you're doing a bridging case and you're with the family constantly, you start to notice things that maybe the family doesn't. So I try to keep my eyes open for that. Oh, you're starting to go to church. Okay, is there anybody at church? Or the kid wants to play hockey. Is there any parents at hockey? So doing that, I think, is important too.
Tyler, any thoughts on your end? Just what are some things you would want other therapists to know that are doing this work?
Yeah, I think it's something that I've am in a continual learning process with, just being an SFT therapist, but particularly with the CIBS program is the focus. You know, I talked about the keeping your eyes on the prize, basically, on your overarching goals. And so it's trained me to be a very focused therapist, to know exactly what I'm aiming at, rather than, any one of 12 different things that could be worked on in this family system. So that's something that I'll always be in a learning process of that, I think, but I've definitely come a long ways with that, and working in this program, I see a lot of value in that. It's made me a better therapist all around.
Okay.
Yeah.
I think one of the things that I've seen as therapists mature in this model is really their understanding of the system being the focus of treatment, and really even beyond the family system, but that the entire set of systems that are surrounding this family, either as part of treatment or who they interact with. And so, because I think some of the interventions that we've even done have been part of trying to shift systems, maybe not necessarily even the family system, but those involved with the family system, to see if we have a corresponding shift then within the family system.
Definitely. Learning how to, I think we're all taught in our MFT programs and so forth, about person or a family's ecology, but we really work that ecology. It's how I like to think of it. So anybody that's a player in this family lives could be potentially a point for intervention and change, and yeah.
I know you guys reference this too, but it bears repeating, just about the work on the front end. And maybe, Sarah, could you speak a bit about that, how the work on the front end makes such a difference over the course of the case or on the back end?
I think being in contact with all the collateral resources, whether that's paperwork stuff like past DAs, that's super important to get all that background information in case stories change or morph over time. I think setting up the groundwork with all the different people that you're going to be working with, RTC people, case managers, county people, even our CIBS team here at FACS, prepping the case as we're going in, I think is really important. I just think the most important piece is just the communication on that front end. It's just so integral, because if you set that mood right from the start, then everybody knows what to expect from you. I am going to call you at least every other day, social worker, so be ready for that. And I think that's important, especially when you have workers that may not have experienced this model before.
Right.
That would be the point, and you touched on it at the end there, but that would add to that, that it being such a new model or newer model, you're going to work with folks out there in the rest of the system that may not be nearly as familiar with it as you. So you, not that you're pulling them along, but it's part of your role is to educate them and help make sure everybody's on the same page and understanding where we're going with this model.
I'm curious how much pressure the two of you feel in doing this type of work, because there's certainly an expectation that you're maintaining the clinical lead throughout the case, that the entire system or referral sources are looking at you to be the change agent, or at least to help facilitate that process with these families. Maybe talk, if you can, just talk about the responsibility perhaps that this model places on your shoulders as a therapist.
Yeah, well, that segues right off of what I was just saying. I guess now that I've been working this program a while, I'm more used to that, but certainly anybody new coming into this, that's maybe could be one of the bigger challenges, because you're being asked to be the clinical lead among other folks who have their own level of competence and so forth, and their own way of doing things. Like a therapist at an RTC would be an easy example, who's also going to be working with your child, your client child, while they're at the RTC. They're used to doing their thing the way they do it within their normal, usual RTC program, which is very different than what we're utilizing them for. So you really have to play that role of the great collaborator and the great mediator, to try to help everyone come along and on your track, but without stepping on toes, and without making anyone feel like you're saying that they don't know how to do what they do or something. You're just trying to educate them about the way we do this, and how can we utilize their skills and competencies within this model.
Yep.
So,
Anything you would add, Sarah?
I do think it is really stressful, but just exactly what Tyler said. But if you are communicating from the beginning all the way through, there won't really be any surprises. It is intimidating to go into a room full of professionals, mental health professionals, and you're the one to feel the pressure on your shoulders. But if you're communicating, then there won't be any surprises, hopefully.
Right.
yeah, if you're communicating often enough, when you do go into official
Right.
staffings and stuff, there's really nothing
know.
new going on in there. Everybody already was in contact with each other, so we all kind of know where we're going. Yeah. And the more we do it just in the life of this program, the more we work with the folks that we do, the more they are used to and expecting that that's the role that we're going to play. And so even the life of the program is, I think, makes that easier over time too, regardless of ourselves individually.
Any final thoughts that you'd like to share with therapists who are looking at doing this type of model? Just any words of encouragement or things that you'd really like them to know before we sign off here?
I would encourage anyone who wants to take their skills and their efficacy to a higher level to take a look at this program. I haven't been a therapist for 20 years by any means, or 30 or 40. But I can definitely say it's brought my skills to a much higher level than I think I would have been at over the same period of time if I wasn't involved in this type of a model. And the efficacy that we see, we're seeing excellent results, numbers on paper results through that the counties and ourselves are tracking. And I think for me that speaks for itself as well. I would encourage any therapist that this would be. I think this is a way of the future type of model. Yeah.
I would agree with that, and then I would also add that I think self-care is really important when you're working with intense families and kids with some pretty usually traumatic backgrounds or tough family systems. And I think using consults with the CIBS team is really important and can kind of help you keep that eye on the prize that Tyler keeps referring to. So
Yeah, for sure.
it's an important piece.
Yeah, we definitely shouldn't sugarcoat that these can be very difficult family systems to work with on the other end of it. So yeah.
Great. Well, thank you, Tyler and Sarah, for sharing your experience and your expertise regarding this model. And thank you for joining us for this segment. Please check out our other segments related to this model, and we'll see you again soon. As you have seen, Collaborative Intensive Bridging Services provides an intensive yet effective way of treating youth with behavior problems and the families they live in. This program helps to minimize the problems caused by placing a child outside the home and treats the problem behavior in the environment which it occurs. As our model continues to evolve, we look forward to continuing to provide high-quality, integrated care to the families we serve. For more information about CIBS, please contact us at contact@cibs.org. at facts, FACTS-MN.org.